Hello everyone, thank you for taking the time out of your evening to join us for this Preparing for Fertility Treatment webinar with Professor Charles Kingsland. Following the presentation, he will be responding to your questions. You can send these through at any time during this evening's webinar via the Q&A panel on the right hand side of your screen. I will now hand you over to Professor Charles Kingsland.
Thanks, Sam. Hello everybody, and welcome to this webinar. My name is Charles Kingsland. I've been a consultant gynecologist in working IVF and fertility now for 35 years, and I've been the chief medical officer for Care Fertility since 2017. So I've been knocking around for quite a long time, and I thought it would be nice today just to go through the preparation for fertility treatment, what it's all about, all the different aspects of the treatment, and at the end, if we've got time, I shall be more than happy to answer any questions that you put to Ashley or Lauren. And if we can't get through the questions in the allotted time, then I'll get back to you via email. So if we could just have the next slide, Sam. Care Fertility is the largest provider of fertility care in the United Kingdom. We now have, I think we have about 25 clinics in the UK. We have a staff of about 1,000, and then 2 years ago we decided to spread our wings beyond the UK. We now have 4 clinics in Spain, and last year we opened our very first clinic in the USA in North Carolina, in a city called Charlotte. So we now have a staff of about 1,000, and the unique thing about Care Fertility is that we are all dedicated to the treatment of couples who are having difficulty in achieving a family. That's all we do. We focus in on that, and we've got 25 years experience. And the nice thing is that there are 75 consultants and over 100 fertility nurses that we can share our knowledge with. If we do have any issues with particularly challenging cases, we talk with each other on a regular basis. So you've got all that. We've got all that experience within our group. Next slide, please. So if you have decided that you want to start a family, and you may be having difficulty, you might be trying for a number of months and getting very anxious, the definition of a potential fertility problem is that if you've been trying for a family for more than a year under the age of 35, and for more than 6 months if you are over the age of 35. Now, there is a reason for that, and we'll explain a little bit later on why we have a definition between 35 and under 35. So what can you do to help yourself? A lot of the things that I'm going to say are relatively straightforward, and you think, well, yeah, that's a bit obvious, but it's amazing the difference that these particular things can do. First of all, lifestyle. Fertility, for those of you having difficulty starting a family, can be a very stressful disorder. And it is a disorder because if you think about the definition of a disease, what is a disease? A disease is actually anything that puts you ill at ease. And if you're having difficulty achieving a pregnancy, you are ill at ease. So anything that reduces the stress that you're undergoing during your everyday life will be of benefit. Get a lot of sleep, have a good diet. Now, when I say good diet, it's actually increasingly difficult to eat good quality food. If any of you have heard of a book called what's it called now? Ultra Processed People by a doctor called Chris Van Tulleken. It is a brilliant book about the food industry and what we are fed in the 21st century. And if there's nothing else you remember about tonight, get that book, because it tells you an awful lot about the food we eat. And there's a lot of food that's very easily accessible, which is relatively poor quality, calorie dense. So you get a lot of calories and extremely tasty. Why? Because it's full of E numbers, lecithin, emulsifiers, plant proteins, which are very easy to grow in the clearings in the Amazonian rainforest, and is readily available, marketed to death. So we recognize the food products and we go and buy them, and they are of very little benefit. Like, for example, you know, health foods that you see in local supermarkets, it is rare that they are of undoubted benefit to your health. And anything that's got anything that, like, you know, a health connotation in marketing, like, I don't know, Nutri-Grain or farm nutrient, or, you know, a sort of a term like that, is probably not much good for you. If you get a good diet, a good quality diet with wholesome food, then you rarely need to supplement your diet with vitamins. For the ladies, folic acid unequivocally is of benefit for you. So anybody who's wishing to start a family, take folic acid. It has been proven beyond doubt that women who take folic acid have a better chance of having a healthy baby than women who don't take folic acid. All of the vitamins and supplements are, in theory, may be of varying benefit, but very few have been shown to be of significant scientific fertility enhancing. For example, you know, fish oils. You are actually better taking fish oils in oily fish than taking them in tablets off the shelf. So if you're gonna supplement your diet with omega-3, take it in a fish, in an oily fish, as opposed to having to go to a health food shop and buying the medication. Similarly, there's a lot of things that are on the market, magnesium, and there's one that's recently been marketed as magnesium fresh from the Irish Sea. Well, I don't know what the Irish Sea is going to have some fertility enhancing benefits, but you can get all these things by eating a good, healthy diet. Body mass index, there is no doubt that your fertility is higher when your body mass index is between 20 and 25. Now, your body mass index you can measure by, it's your weight in kilograms divided by your height in meters squared. And if your body mass index is between 20 and 25, your fertility is probably greater than if your body mass index is over 25 or under 20. And we all know people who might have a body mass index of 35, 36, 37 with children, but they may be starting at a different level of fertility than we are. And there's no doubt that if you manage to get your body mass index between 20 and 25, you are at in a better state to have a healthy baby than if it's below 20 or over 25. Now, I know it is really difficult to get down to your boxing weight, and often I like to think of people who have who may be overweight or significantly overweight to be victims of the food industry, because there are so many people out there who are trying to seduce us into eating stuff that's really not good for us. So just be very careful about what you eat. Any current contraception? Well, I always say that it's important that women think about regulating their fertility at a time in their lives when they don't want a family. But when you have decided that the time is right, and you're on the oral contraceptive pill, for example, try and come off it, 3, 4, 5 months before you really start to think about concentrating hard on having your family, because sometimes it takes a little bit of time for your hormones to kick back in after they've been quiet under the influence of contraception. Contraception doesn't reduce your fertility, it just sometimes you need a bit of time to kick back in. Finances. Now, unfortunately, it's the way of the National Health Service that fertility is a very high profile disorder. So hardly a week goes past, hardly a day goes past without you getting some stories about fertility or what's been happening in fertility, often misleading. But you know, stories about fertility are of great interest, you know, because they're sad beginnings, happy endings, damsels in distress, nasty doctors, wicked scientists, babies. It's got everything that a good story needs. But unfortunately, the priority amongst the National Health Service is low for fertility. It's actually, since post-COVID, gynecological and women's health services are underfunded. Anybody who's had a benign gynecological disorder will know that if you're referred to your local hospital, waiting times can be over a year, and fertility therapy is the lowest priority amongst women's health. And that means that you have to wait a long time, and it's underfunded. So in Britain, only about 40% of the population can have access to comprehensive fertility treatment that they need across the board. And different areas will fund fertility to different levels. So there are some areas of the UK where you don't get treatment at all. There are some areas, like my area, which is in and around Liverpool, which is much better funded, so that if you're under 42 years of age and your body mass index is under 30, and there's nobody on the planet that calls you mummy or daddy, you get access to fertility treatment, albeit with quite a long waiting list. So this means that a lot of you, in fact, the majority of couples or individuals who want fertility treatment have got to pay for it themselves. And people always think that fertility is very expensive. And it is expensive, but relatively, compared with other treatments, it's not. So if I just gave you, as an example, the National Health Service, to run a hospital theatre costs £25 a minute. Each NHS consultation in an outpatient costs the National Health Service £108. If 3 people don't turn up for their National Health Service appointment, that's cost the National Health Service over £300. Laparoscopy costs 4,000. IVF costs, to most people, 6,000 or 7,000, depending on who you are. So, you know, it's not an insignificant amount, but relatively, it's not massively expensive in NHS terms. However, if you need fertility therapy and you don't get it on the National Health Service, you've got to think very carefully as to how that can be funded. Also, finally, you've got to give yourself a plan as to how much time of your life you're going to dedicate to fertility treatment. And I often say to patients, you know, after the initial tests, how long are you going to spend coming to the fertility clinic? It might be 6 months, it might be a year, it might be 2 years, it might be 5 years. Everybody's different. But you've got to set out how much time in your life you're going to dedicate to helping, or to try to help you to have a family. How much money you're going to spend, whether it's 5,000, 10,000, 15,000, 25,000, you know, it's up to you as to how much you're going to spend. Now, if you know what your budget is, if you know how much time you're going to devote, then hopefully your gynecologist or your specialist in fertility, or your clinic, will tell you what your chances are, not what the chances of the clinic are, or what the average success rate is, or how successful the clinic is. What are your chances of having a baby? So that then you can meaningfully budget as to time, your health, and also your expenditure. and everybody's different. What you do have to know, though, is the information at the outset so that you know how much money exactly you're going to spend. Because what you don't want is halfway through somebody else coming along, oh, well, you know, well, that's parts plus labor plus VAT, because we all you know workmen who come to your house and say, give you an estimate, and then it turns out to be twice as much. You need to know for your own mental and physical well-being how much money you're going to spend. Next slide, please. So I'm going to quickly run through an overview of male and female infertility. The first thing we have to remember is that the difference between boys and girls is that girls are egg warehouses. All your eggs are in your ovaries on the day you are born. You cannot make eggs. You certainly cannot make them better. They are at their best in your 20s, and then as you get older, your egg quality and hence your fertility declines. It drops like a stone over the age of 30, 35, and that's why we have a cutoff of 35. Under 35, then egg quality should be pretty good, but over 35, a bit like, you know, professional footballers or athletes at the Olympic Games, your performance starts going down. That's next slide, please. That's a little bit different to males. We are sperm factories. So unlike females, we have all the ingredients in our bodies to make sperm every single day of the week. Some days we're good at it, some days we're bad at it. It usually takes us about 6 weeks to make a sperm. We then store them for a variable amount of time, ejaculate them out, and make some more. As we get older, our sperm manufacturing apparatus declines, but not as quickly as females. So we can, in theory, maintain our fertility significantly longer than females can. And Charlie Chaplin had his last child when he was 85 years old. Amazing, isn't it? They obviously didn't have Sky Sports or mobile phones in those days, but that's the major difference. Next slide, please. So what normally happens is that halfway through a female cycle, if she has a regular cycle, she will release an egg. That's the process called ovulation, and it rolls down the fallopian tube, which are the two little tube-like structures that attach to the uterus or the womb, and then they get wafted down the fallopian tube by tiny little hairs. Now, if that female has sexual intercourse or has insemination at the appropriate time, sperm are deposited in the vagina, and up they swim through the cervical mucus, through the neck of the womb, the cervix, into the uterus. They turn right or left and meet the egg in the outer third of the fallopian tube. And then either one sperm will swim into the egg and fertilize it, and you've got yourself an embryo, or the sperm don't make it. Now, for a sperm to swim from the vagina to the outer third of the fallopian tube where the egg will be is the equivalent of a man swimming from Liverpool to New York at about 600 miles an hour. So they have to swim a long way. That's why sperm are actually kept in testicles which are outside the body, because they need to be kept cool so that they can swim better, whereas eggs are in their ovaries, which are inside your abdomen, because they like to be kept nice and cool. Next slide, please. So, what are the tests that we do? There are 3 tests that we need to do. 3 important tests. All the others are of secondary importance, but the 3 questions that we need to know are, number 1, for the female, have I got eggs in my ovaries? Are all my bits in the right place? And number 3, for the male, do the sperm that are that are ejaculated have the ability to swim to the female's egg. So, question number one, have I got eggs in my ovaries? The test we do is a blood test, and it's called AMH, anti-Mullerian hormone. It's a hormone that's produced by your eggs. So the more AMH you've got, the more eggs you've got. It doesn't tell you about the quality of the eggs. It tells you how many eggs you've got. And, you know, if you've got a high AMH and you're 38, well, that means you've got a lot of 38-year-old eggs, which is, you know, it's better than having a few. But if you're 25 with a low AMH, your fertility is probably higher because although you've got a fewer number of eggs, they are only 25 years old. There's nothing you can do to make those eggs better. All you can do is to stop them getting worse. So there are things you can do that unequivocally preserve the quality of your eggs. Don't smoke. Try not to be overweight. Eat well. Get lots of sleep. And of course, be young if you possibly can. So that's the blood test. There's another test we can do on an ultrasound scan called the antral follicle count, and that measures the number of follicles, they're little fluid-filled sacs that can contain eggs which surround the egg. We can surround the ovary, and we can measure the antral follicle count on an ultrasound scan. So that's how I got eggs in my ovaries. The next test is, are all my bits in the right place? And the test we need to do is an ultrasound scan, which can tell you virtually everything you need to know. You don't need to have special, you know, x-rays or high cosies or low cosies or this, that, and the other, or selective salpingography. A scan will do it by a good ultrasonographer. You can also give a, you know, and what you tell the ultrasonographer about your history, or the doctor about your history, whether you've had sexually transmitted diseases or whether you've had endometriosis or something that can affect your tubes, we can see most of it on the scan. So by and large, we just need to see 2 of everything down the sides and 1 of everything up the middle. And that will give us a good idea as to the female fertility performance. Eggs in your ovaries and all your bits in the right place. Now, do the sperm have the ability to swim to the egg? We check with a semen analysis. So what we do is we ask the male if it's a heterosexual couple, or if in the case of same-sex couples or an individual, we want a sperm analysis from the sperm sample. For a heterosexual couple, we would like probably 3, 4, 5 days of abstention. Then the male produces a sample in a pot and brings it to our laboratory, and we look for 3 things: the number of sperm, the quality of the sperm, how many are normal and how many are abnormal, and whether they are doing front crawl, backstroke, doggy paddle, or breaststroke. So what we want is 15 million sperm per mil. That's the number that we want. We want at least 40% to be doing front crawl, i.e. swimming, you know, in the case of Scousers, towards the New Brighton Lighthouse on the way to New York. And we want only 5% to be normal. Believe it or not, 95% of the sperm that we make of humans is abnormal. We want 5%. So we want 15 million per mil, 40% doing front crawl, 4%, well, it's 4 or 5% normal morphology. And they're the tests. They are, and if I've got those 3 tests in front of me, that's all you need. You don't need fancy alpha, beta, gamma, glutamate placental transferase tests at 300 quid a shot. For some people, you know, you might need it, but for the vast majority, they're the tests you need. On the basis of that, we can then decide what the best treatment for you is if you're having difficulty achieving that pregnancy. Next slide, please. So, you know, I say that you've got to be trying for over a year, or if you're under 35, or you've got to be trying for 6 months under 35. It doesn't matter. It's how you feel. if you're stressed out your head just by you know, trying for 2 months, just give us a ring and we can, you know, put your mind at ease. You don't just suffer in silence. Similarly, you might not even want to have a family, but you'd like to know, just out of interest, am I, to all intents and purposes, do I, you know, have normal fertility parameters? Now, you never can prove unequivocally that you're going to have a baby, but there are some pointers that you can look towards, and we can do, you know, some sort of fertility testing. It won't tell you whether you're going to have a baby or not, but it can give you some, it can tell you, you know, whether you're, you know, have a reasonable chance, a good chance. But anyway, if you've decided that, look, I need some help, go and see a fertility clinic. And you will normally, in the case of Care, you'll phone us up, and our Care pals, girls or boys, will take your call and point in the direction of the best clinic. And you will have a consultation with the consultant. This is actually George. He's our lead consultant in one of our great clinics in Sheffield. And during that consultation, they will ask you, you'll be asked all the questions that might signify you have a fertility problem. It might be that there's nothing. And in fact, in a lot of patients, in fact, at least 50%, there is nothing. There's no signifiers. But things like, are your periods regular or irregular? Irregular periods, you may not be releasing an egg. Regular periods, you will be releasing an egg. If you've had chlamydia, and, you know, or sexually transmitted disease, it might have affected your fallopian tubes. If you're a male, you've had undescended testicles as a child, or mumps as a teenager, or you smoke heavily, that might give you an impression that you've got a poor, a low sperm count. But the tests we then do will nail that diagnosis. Next slide, please. So after the consultation, and the tests, we will make a recommendation as to what is going to give you the best chance of having a child. And if it's me, I tell you how long it's going to take, how much it's going to cost, and what are your chances, because that's what you as an individual need to know. Not, you know, every Tom, Dick and Harry that comes into the clinic, or our human fertilization embryology authorities, you know, outcomes. We want to try and do it for you. And based on that, you will then need to decide, yeah, I want to do this, or no, we're going to try a bit longer, or we're going to, you know, seek take some time out. But anyway, if you decide, yeah, let's go for it, this is what happens. Next slide, please. So a lot of you, not all, a lot of you who come to Care Fertility will require at some point IVF. Now, IVF is a very, very standard technique. You hear lots and lots of mystical stories about IVF, and it always makes me smile, you know, that we are obsessed about success rates and of IVF and this, that, and the other. Well, you know, how many people go when they go to their local hospital with pain in their abdomen and they need an appendectomy? I wonder how many people say, "What's your success rate of taking appendix out?" Or how many appendectomies has this particular doctor done? I can't remember, you know, my 30 years as a consultant gynecologist, I don't think many people ever asked me how many hysterectomies I'd done before I was going to do a hysterectomy. But everybody gets bogged down with success rates. And I'll tell you a little secret based on my experience. It doesn't matter where you go. It matters who you are. The success rates of the vast majority of clinics you go to are very, very similar. But your choice of fertility clinic is very important to you. Do you want to go to a massive clinic in a big tertiary centre hospital? Or you want to go to a small clinic? Do you want a particular consultant? Do you want to be able to park next to the clinic door? I know it sounds a bit silly, but that's really important. Can I drive up to the clinic? When I walk in, will the receptionist know who I am, or will I be sitting in a room full of anonymous people? Everybody's different. Some people want to be anonymous. Others want to be, in a more intimate environment. And there is a clinic that suits you. You might not want to go very far, or you might want to go a long way. But most people that I know want to go to a smallish clinic who have an individualized plan for you in particular, where you can park and it's close to where you live. So you can nip in and nip out, and it's of minimal disruption in your life. But IVF itself is formulaic. For 80% of people undergoing IVF, it's very standard. And this is the process by which we all go through it, irrespective of whether you have, natural IVF or minimal IVF or fluffy bunny IVF. It's all the same. We just market it differently. So this is the way it goes. The first thing we do is we stimulate your ovaries. So instead of producing 1 egg in the cycle, we want you to produce 9, 10, 11, 12 eggs. So we just give you a higher dose of the hormone that you normally produce, which stimulates your ovaries to produce lots of eggs. And then we watch them grow by scanning you a couple of times on baseline and day 9. And then this is the process. This is one of our nurses showing you how to draw up the injection fluid. So you have a daily injection of the hormone FSH, and then we monitor the growth of your eggs by ultrasound, normally a couple of visits. This is the ultrasound machine. It's a vaginal ultrasound, so the tip of the vaginal probe goes into the vagina. It doesn't hurt, and we can scan your ovaries very carefully and look at the follicles growing. These are the fluid-filled sacs in which the egg grows, and we know that once they reach a particular size, then they're mature. The eggs inside are mature. Next slide, please. So what happens when 3 follicles have reached 2 centimeters in diameter, that we know it's like apples on a tree, that those follicles are ready to be collected? And we give you what we call a trigger injection. Now, the trigger injection is usually, we give it 35 or 36 hours before your egg collection. And the trigger injection does 2 things. Number 1, it softens the follicle so that the sac becomes soft, and it completes the maturation of the egg, sort of polishes it off, so that 35 hours after the trigger injection, you come for your egg collection. Now, the egg collection normally takes about 15 minutes. It's done with you sedated. You're not anesthetized. You're just zonked out, so you're aware, but you shouldn't feel much discomfort. You'll obviously feel a bit, but it shouldn't be too bad. And we put a little needle through the top of the vagina, which is attached to the vaginal probe, and just push it into the ovary, into the follicles, the little fluid-filled sacs, and we suck out the eggs. Takes about 15 minutes. You wake up, have a cup of tea, and go home. Next slide, please. During this time, the male, if you're in a heterosexual relationship, or if you're in a same-sex relationship, we will get the sperm, the donated sperm, ready for you. The male will whilst his partner is having her egg collection, will have produced his sample in the clinic, and then that's passed through to the laboratory, and the embryologist will start working on the sperm to make sure we've got the best sample available for when the eggs are ready. Next slide, please. So what happens then is that if you've got a good sperm count, we'll put 100,000 sperm. Remember, you've got 15 million per mil. So we've got 100,000 sperm, and we will put them with 1 egg. So 100,000 sperm in 1 egg, and then we put them together and close the lid on the incubator and leave them there for 3, 4, 5 days, and we don't disturb them. If, however, the sperm count is low and we think that the sperm might not have the power to swim into the egg, we then take one single sperm, we chop its tail off to stop it wriggling, and we inject the head of the sperm into the egg to give it a flying start, if you see what I mean. And that is called ICSI, intracytoplasmic sperm injection. Now, just to give you an idea as to, you know, how quickly we've progressed in IVF, the first ICSI babies were born in the mid-90s. Before that, we had no treatment, no effective treatment for a low sperm count. Amazing, isn't it? Now I can remember having a twin pregnancy in my clinic where the male had got not 5 million or 5,000, but 5 sperm in his ejaculate, just 5. And he's got a healthy twin boys who are both Evertonians. Well, you can't have everything. So next slide, please. And this is the IVF process. This is one of our girls from embryologists from London doing the fertilization check. Next slide, please. And what we do now at Care, we have a process called time-lapse technology. So years ago, what we used to do, we used to get the embryo, have a look at it on the microscope, put it away again, get it out the following day, have a look to see whether it's grown and developed, put it back, get it out the next day, and have another look. But nowadays, we don't need to do that because we actually video the embryos. We video them and take little photo shots every 10 minutes to look at the growth and development, not only how quickly they develop, but how quickly they divide. That's called time-lapse technology, and it's brilliant. We have a particular algorithm based on 500,000 embryo developments, which called Care Maps, which actually gives us an indication based on how quickly they grow, how quickly they divide, which embryos are likely to turn into babies. And we've coupled that now with AI, artificial intelligence, which we now call Care Maps AI, which gives us a really quite accurate assessment of the embryo development over 3, 4, 5 days. 30 years ago, we could only grow embryos up to 2 days old because we didn't have the technology available to us to get them to grow beyond that. Nowadays, we grow embryos to 5 days, and that is when they are 100 cells big, and we call that a blastocyst. Of course, if you get a blastocyst, that means that they've actually grown for 5 days in the laboratory. So they are, we can assess them far more accurately, and that's why we nowadays only put one embryo back, because we have a far better idea of the quality of the embryo than 20 years ago when we had very little idea. So we used to put more than one embryo in the hope that one would stick. The downside to that, of course, was that often 1, 2, or 3 would stick, and humans are only designed to carry 1 baby at a time. 2 are to push, 3 very rarely. So we always, you know, if you've been trying for a baby, we always say, oh, well, wouldn't it be nice to have twins? Twins, it's great to see happy, healthy twins being pushed around Morrison's or Aldi, but you don't see all the tragedies, the prematurity, the miscarried and ill twins that are born just because there's not enough space for them in the uterus to grow well. Next slide, please. So I've just talked about Care Maps AI, but we also have another neat procedure. Care Maps AI gives us what we call morphokinetic information. Morphology is what they look like, kinetic, how they move and how they grow. But the only way to know exactly what the constitution of the embryo is to biopsy it. And that's called PGTA. And we take a number of cells, 4 or 5 cells from the 100 cells in the blastocyst, and you can see that on the 3rd slide, and we look at the genetics of that embryo. If it's euploid, it's normal. If it's aneuploid, it's abnormal. So the only way to really know whether that embryo is normal or not is to biopsy it, PGTA. Care Maps will give you a good idea, PGT will give you a real idea. What we have to remember is that 50% of all the embryos that humans produce, irrespective of whether they're natural or in a laboratory, are genetically abnormal. And that is why humans miscarry so often, because when a female miscarries, we always think that there's we talk about, oh, I've lost the baby. And there's this notion that there's this tiny, well-formed baby hanging on by its fingertips saying, please, mummy, don't let me fall out. 95% of all first trimester, the first 12 weeks of pregnancy miscarriages, are genetically abnormal. Humans very rarely deliver genetically abnormal babies. The commonest one is where there's a genetic abnormality of the 21st chromosome, trisomy 21, which is Down syndrome. And what you have to remember is that for every 100 Down syndrome babies that are conceived, for every 100 Down syndrome embryos that are made, naturally only one is ever born. 99 will miscarry. That's why Down syndrome babies, I perceive, are always very special, because they battled through nature to get to be born, whereas the majority will be miscarried. That doesn't mean to say that miscarry, we should take that lightly, because women who miscarry have still lost a baby, and we have to grieve correctly at the right time. That's why people feel it's no point in saying, if you've miscarried, oh, well, it's not the end of the world, you can always try again. At that particular stage, it is the end of the world, and you need to have to get over it and grieve and feel better, and that can take some time. So never underestimate a miscarriage and the effect it can have. Next slide, please. So nowadays we create far more embryos than we actually need, and one of the great innovations that have happened over the last 10-15 years is our ability to successfully freeze embryos. Years ago, we only had, freezing embryos was only about 50% successful. We lost 50% of embryos during the freezing and thawing process. Nowadays, 98.5% of the embryos that we freeze, we can thaw and use. So freezing embryos frozen embryos have the same success rate as fresh ones. And actually, in most cases, I would suggest that embryos are best off being frozen, so that you can get over the egg collection. You can, instead of having fresh embryos put back at a time when the hormones are still rushing around and you might still be a bit in discomfort from the egg collection, and it might not be appropriate. Well, have your embryos frozen and come back next month, and we can put them back, thaw them and put them back at a time when it's convenient for you and for the laboratory, and the chances of success are exactly the same as if they were fresh. If you have pre-implantation genetic diagnosis, if you have an embryo biopsy, you have to have your embryos frozen, because it takes 2 weeks to get the result. So you can't put the embryo back until you've got the result. So we freeze all PGT-8 embryos. Next slide, please. I've actually seen, and it's the world record in my clinic in Liverpool. We had a woman who had a couple who had embryos, had 5 frozen embryos frozen. They then went on to have 5 babies 10 years apart. So the youngest was 10 years younger than her older sister, but they were all conceived on the same day. Born 10 years apart, but conceived on the same day. Amazing, isn't it? So embryo transfer. We've decided we've got 1 embryo to go back. Have as many embryos back as you like, as long as it's 1 at a time. That gives you the best chance of having a healthy baby. The embryo transfer procedure is very straightforward. You just come in and the embryo is placed in a catheter and then injected through the cervix and into the uterine cavity under ultrasound control in the most cases, so we can see where we're depositing the embryo. Some clinics don't do ultrasound because the doctors are very skilled at the technique, so they don't sometimes need that ultrasound support. I do. I like to see where the embryos are going. So the embryo procedure takes about 5-10 minutes. It's painless, and then you get up. Don't feel as though the embryo is going to fall out. An embryo at that particular stage will sit on the sharp end of a pin. So when you stand up, it's like a bubble in a bottle of pop. As you stand up, the embryo actually floats up. And if you want to empty your bladder after your embryo transfer, because often we'll ask you to come to the clinic for your embryo transfer with a full bladder, because it flattens, the bladder pushes the uterus down and makes the passage into the uterus straight, so we can put the embryo back a little bit easier. When you go and empty your bladder, the bladder is lower than where the embryo is, so you don't feel as though you're going to wee the embryo out. You actually, the embryo goes, as you empty your bladder, the embryo goes further and further up. Then, what turns that embryo into a baby? I don't know. Nobody knows. We just have to keep our fingers crossed. That's called the 2-week wait. You take progesterone, cyclogest, or progesterone supplements. That's the hormone that makes the embryo stick to the uterus, and then we just hope for the best. And there is nothing that you can do to help or hinder the journey of that embryo into a pregnancy. Obviously, you don't want to go skydiving or compete in the Olympics or something like that, but take it easy, go to work, keep the body pumping, keep the muscles going, don't go mad, but don't just lie there in bed. Years ago, we used to have patients lying in bed for 2, 3, 4 days after embryo transfer. No evidence to suggest that that's of any benefit. Bed rest does not help. Get up and move around quickly. Next slide, please. For some people who don't need IVF, IUI is a very popular option. Intrauterine insemination. So instead of putting the sperm through sexual intercourse or in IVF right next to the embryo or into the vagina with sexual intercourse, we inseminate. We take the sperm, we process it, we concentrate it, and we inject it at the right particular time in the patient's cycle right into the uterus. So instead of asking the sperm to swim from Liverpool to New York, we drop them off halfway across the Atlantic and then just ask them to do the last bit on their own. In the case of individuals who require donor insemination, this is what we do. We inseminate. We do an intrauterine insemination using donor sperm. But as I said, the consultation, when you see your fertility practitioner, they will tell you what the best treatment or the optimum treatment options are for you. Okay, next slide, please. There are also nowadays we have a broad diversity of families. We have a lot of same-sex couples who wish to undergo shared motherhood. I think this is pretty neat, where we have in same-sex couples we have the eggs from one partner fertilized with donor sperm and the embryo put into the uterus of the other partner, which is called shared motherhood. So the partner 2 grows the baby, delivers the baby, has the baby, but partner 1 is the genetic mother. So partner 2 is the birth mother and partner 1 is the genetic mother. And I had a couple who are neighbours of my eldest daughter who had their first shared, the same-sex couple who had their first shared baby, and they had a beautiful little boy who they called Fox. And I was at a christening actually, and the mothers were there, and I said, "Well, that's an unusual name. Why did you why do you call him Fox? And they said, well, we didn't know what we didn't have the names finalized. And then we were driving when my wife was in labor. We were driving to the hospital, and just as we were coming into the hospital car park, a fox ran across the car park. So we decided to call our baby Fox. And I've always thought, good job we wasn't a hedgehog. But anyway, they've gone on to have another little baby now, another little boy, and they are both gorgeous. Shared motherhood. Brilliant. Next slide, please. There are some circumstances where couples don't have, where the female doesn't have any eggs. She's either born without eggs or has run out of eggs. So we can use donated eggs. These are eggs that have been donated to us, and we put them in our egg bank. We freeze them. We also work with partners, the California Cryo Bank, Cryos International, European Sperm Bank, Fairfax Born Donor Bank, London Sperm Bank. These also, if we need donor eggs, we can also get donor sperm. This is for individuals who want a family as a single mother, or same-sex couple who need sperm donation. And we will support and help all same-sex couples, all individuals who need advice as to where to get their donor sperm from. Don't feel as though you're on your own. This is what we do all day long, 24/7. So we're here to help you. Next slide, please. So we can also help you with known donation. We can put you in contact with our egg banks in Europe. We also have the most sophisticated egg donation programs are actually in Spain, and we have 4 clinics in Spain. So for any couple who wish to go overseas, you know, if you can't beat them, join them. Come to our clinics in Spain. And sometimes, you know, going back to where we live in Liverpool, there are 5 flights a day to Alicante, and it costs about 40 euros return, where it's 200 quid on the train to London. So you're just as easy going to Alicante, where one of our clinics are, than maybe going to the UK. Everybody's different, and we can give you information regarding support for egg donation. Don't feel as though you're on your own. That's what we do. Okay, next slide, please. We also have a very successful surrogacy program, which won the National Surrogacy Awards last year. This is where a female, through disease or genetics, has been born without a uterus, or there's some medical reason why she cannot carry a baby herself. She may be able to produce embryos, but she can't carry a baby. And I saw a lovely couple last week who the mother has had some very serious medical disorders. So much so that she cannot carry a baby herself, and she's now undergoing surrogacy at one of our clinics, where we support the couple by providing them with a surrogate. And you know what? She's gonna have a baby. And why do I say that? Gut feeling, based on 35 years of experience. You just know. And I wish her all the very best. And we have a clinic dedicated to, we have a dedicated surrogacy nurse practitioners who are experts in supporting, helping and advising couples who think they may need surrogacy. Next slide, please. I don't really want to go into the different types of surrogacy. Safe to say is that we can support either with host surrogacy or direct surrogacy. Just give us a ring and we can talk you through it. Next slide, please. And what about support? We've already mentioned that you know, the fertility journey, having a fertility problem is stressful enough, but then having to go into the wide world of fertility therapy with all the clinics and all the marketing and all the different, you know, we can do this, we can do that, we are the most successful at this. You need some really sound advice. And the most important thing is gaining the trust of somebody who is there on your side, whether it be a clinic, an individual doctor, or just an individual nurse, but to provide that continuity so that there's always somebody there for you. And I hope that at Care that we can do that, and we've been voted the most trusted group of clinics, just to provide that trust. You know, I think as a doctor or as a healthcare worker, the highest compliment anybody can pay you is to say, I trust you. Because that's what it's all about. I trust the clinic. We've also got an app now, which is really cool, which can support. It's called Salve, which can, you know, it can help you stay on top of your medications with reminders, keep track of all your appointments, chat with our team, sign consent forms. Signing consent forms are a pain in the neck, but they have to be done. So we can support you with that. Pay invoices securely, learn about the medication or what's happening to you, and just share your treatment plan with your partner if you have a partner, so that you can just share the knowledge on the Salve app. Next slide, please. We also have, my goodness, I'm going on a bit tonight. We also have payment programs, as I said to you before. How long am I going to be treated for? How much are we going to pay? Well, we now have interest-free programs. We have repayment programs we partner with Access Fertility to provide all of our patients with different payment programs. These programs give you financial security around your treatment, and you can focus on the treatment itself. As I say, it's stressful enough without thinking, oh, you know, what's the next bill that's coming along. Well, we've got all these different programs, refund programs, multi-cycle programs, donor egg refund programs, multi-cycle packages, 100% refund on some programs, so that we can tailor make not only your treatment, but your financial management for you. So it's not going to take away the payment, but it's going to take away the stress. So at least you're securing the knowledge as to how the payments are going to pan out. Next slide, please. We're here with you every step of the way. We've done it all before. This is what we do 24/7. So if you have any questions, no matter how daft you think they are, and believe you me, if you think you've got a daft question, I will have heard 100 dafter than the question you have. But nothing's, you know, when you're all over the place and you don't know what's going on, sometimes you just want little questions. And you know what? I'll let you into a secret. The people that ask the daftest questions are doctors. You know, some of the questions that really informed medical practitioners ask me, you think you should know that, but there again, you don't, because it all goes, you go to mush, and then you're thinking, oh, what was that? What's this? I don't know what that means. And you want to ask once, twice, 3 times, 4 times even, because it might not sink in the first time. The Salve app will help you, and but don't think you're alone, because you ain't. That's what we're here for. So what's the next slide? Support every step of the way. We've got, you know, our counselling, really important. If you feel that it's all getting on top of you, and you know, you want some independent advice, we can provide counselling for you. We have our social media feeds. Be very careful what you read on social media. Some of the most outrageous things that I see on social media. You know, you want to ask things like, what's, you know, I'll just have a quick, somebody tell me to shut up if I'm going on too long, but I think this is really important. Evidence-based medicine. Evidence-based medicine is medicine that unequivocally is of benefit for you. Like, for example, folic acid. Take your folic acid and you've got a better chance of having a baby, healthy baby, than if you don't take your folic acid. Stop smoking. Evidence-based. Smokers are not as fertile as non-smokers. Evidence-based. There are some stuff that's no evidence base whatsoever. So, you know, things like acupuncture. Nobody's ever proven beyond doubt that having acupuncture will improve your chance of getting pregnant. But that's okay, because, you know, if a doctor or an acupuncturist says, I'm going to do acupuncture and it's going to double your chance of getting pregnant, that's not true. But if your acupuncturist says, look, I'm going to do acupuncture on you and it's an old Chinese art and it's not going to be harmful, and you never know, it just might be a benefit for you, then great, do it. And it's a bit like, you know, other stuff, reflexology. I'm all for it because, you know, humans, we love a good legend. We love a good story. I remember once a patient put on social media, Professor Kingsland has magical powers. We've been trying for a baby for 3 years. We went to see him once and within 6 weeks we were pregnant. Now, that, between you and me, is called coincidence. But I'll take it all day long because it's, you know, there is no evidence that me talking to you is going to double your chance of getting pregnant, or apart from giving you the correct advice to get the right treatment. But, you know, you never know. It might just be just that little throwaway line that might be of benefit. But, you know, as Voltaire said, the art of a good doctor is for nature to cure the problem whilst the doctor is treating you. And then the doctor takes the plaudits. And it's a bit like, you know, going to your health food shop and taking, you know, your alpha beta trypsin supplements, and then you get pregnant. That's coincidence. It's not cause and effect. It's not been proven. Evidence-based medicine is what proves it. Next slide, please. Any questions? Right. Oh my word. Sorry, I've gone on a bit, and your tea's probably getting cold, or if it's a salad, your tea's getting warm. What happens with twins? What's the chance of having twins, and what happens then? Well, you know, twins, the human uterus is designed to have one baby. 2 are to push. 3 almost never. Now 4. So if you get pregnant with quadruplets, there's only a 20% chance you'll have one healthy baby. 20% chance you'll have one healthy baby because there's no room to grow. Now, years ago we used to put 2 embryos back because it optimized your chance of getting one baby. Nowadays we don't have to do that because the embryos we grow are much better quality. We can assess them better, so we only put 1 embryo back. Occasionally you'll have 2 embryos, but when you scan a pregnancy and you see twins, there's always elation, but to the gynecologist there's fear because humans are not designed to carry 2 babies. So obviously the majority will be born healthy, but the risk is there. So we only put 1 embryo back, 2 very occasionally. Are you more likely to have a premature baby if you conceive via IVF compared? Absolutely not. IVF babies are every bit as healthy as naturally conceived babies. There is so much myth talked about. Now, what you have to remember, though, is that IVF babies are usually born to mothers who are older. The average age of a woman having her first child in Britain last year was 31. IVF babies, 35, 36. So if you take that into account, yes, women that are 36, 37, 38, 39, 40 years old are not as efficient as having babies. They might be still very efficient, but they're not as efficient as younger people. Just like the gymnastics that I've been watching now. You know, when you're 22, 23, you're going to be much better on the parallel bars than when you're 40. And it's the same as having babies. So there are increased risks as you get older. And those risks, once you take them into account, though, IVF babies are every bit as healthy, every bit as loved as naturally conceive babies. And what you have to also remember is that if you take 100 couples off the street and instead of and ask them to go and have sexual intercourse once or IVF once, now in the group that have sexual intercourse once, you can time it, 8 will come back with a baby. If you take another 100 couples and you do IVF on them once, 40 will come back with a baby. IVF is 5 times more successful than sexual intercourse. You never read that in the Daily Mail, though, do you? But the thing is, of course, I'm talking about people who are fertile. IVF on fertile people works really, really well. But of course, once you need IVF, you've sort of tried the natural ways, and so you're in a different position. So it's not as successful, but still it's successful. Right, I think that's about it. I think we've overrun. I do apologize. I get carried away sometimes, and I hope that was useful and of use to you. As I say, the girls are hold on. Yeah, the girls are on hand to answer any other questions that you might have. If not, we can always get back to you. I'll just answer this one more because I think this lady was a bit. I've had a laparoscopy, hysteroscopy, and adhesiolisis. That means adhesions being removed early this month, revealing extensive uterine scarring and extensive tubal damage due to an emergency cesarean section during my daughter's birth. The consultant managed to remove a great deal of the uterine scarring. Would Care Fertility perform another hysteroscopy to check the Ashermans before implantation during IVF? Or is this something I would need to do elsewhere? We do it, and we would manage the Ashermans for you, because that's what we do. So go to your local Care Fertility clinic, and we will go through that. I have a low egg count, and my partner has a low sperm count. Currently waiting for referral to gynae. Can my partner do anything to increase his sperm count? Keep his testicles cool. Eat well, stop smoking, get down to your body mass index 20 to 25, you're waiting for guy. It depends how old you are. You know, you don't want to wait too long, because the crucial thing is for you as a couple is your age, because if you've got a low egg count, a low sperm count, don't hang around. And that might be worth your while, just paying for a private consultation with Care, as opposed to waiting for your NHS. It'll be, what, 200-300 quid, but it might be money well spent. That doesn't mean, say, you've got to spend thousands on treatment, but it means that you might get the advice you need, and it'll enable you to plan your treatment. Final question, promise, and I'll let you all go home. I'm currently perimenopausal and having HRT treatment, which has been in place for around 5 months. Is there a treatment plan available that can enable me and my partner to move forward with IVF? Answer, yes, there is. Phone your local clinic and we can take you through it. That's, as I said, I've said it once, I've said it 100 times. That's what we do. And so that concludes this evening. Thank you very much for listening. I hope it's been of use to you. I've rattled through lots of information. As I say, Care Pals, our brilliant GEM team are, I sound like an EasyJet pilot introducing the stewardesses. We have a marvelous group here at the back helping you. Well, actually, we have on our care team. It's brilliant, and I'm proud to be working with them all. So good luck. I hope you're successful. I hope it's been helpful to you, and get in touch with your local clinic if you need any further help, and enjoy the rest of your evening. Good night.